Hello and welcome to another fully vaccinated session of In the Faculty Lounge. I'm Paul Hauptman, Dean of the Graduate School of Medicine, and I'm here today with a special guest, Dr. Keith Gray, Chief Medical Officer of the University of Tennessee Medical Center and Associate Professor of Surgery at the Graduate School. Keith, welcome.
Thank you, Paul. Thanks.
By way of background, Keith is a graduate of Wake Forest University for both undergraduate and medical school studies. He had a great time, we hear, at Vanderbilt as a resident in general surgery. So impressive that he ended up in a fellowship at MD Anderson for surgical oncology, and we were really lucky to get him here. He actually preceded me here at the Graduate School of Medicine, where he's become the chief medical officer and is very much engaged in issues of health disparities. And we're going to be focusing on that today in our discussion. But first, Keith, what we often do in the Faculty Lounge is to ask our guests to talk about the decision to go into medicine, and in your particular case, surgery, and then oncologic surgery. What were the primary motivators for you?
Yeah, so Paul, I grew up in eastern North Carolina in a rural community, and actually grew up working on a farm. And to be honest with you, the decision I made, when I made a decision to go into medicine was around 15 years old. And my brother and I were together, and he says, well, what do you want to do when you grow up? And I said, wow, I really enjoyed biology this year. It was anatomy and physiology, and I really like using my hands. And I said, what career can I choose where I get to use my hands and I get to study anatomy for the rest of my life? And it was surgery. But ironically, at the time, I didn't know any surgeons. Actually, didn't know any physicians other than my pediatrician. And so my mom and dad helped me understand and pursue a career in surgery.
And it's been quite the career. I have here a list, Keith, of some of the awards that you've won over the years, and it really began in medical school. You won the North Carolina Board of Governors Medical Full Tuition Scholarship, the Complete Physician Award, Alpha Omega Alpha Medical Honor Society, Healthcare Hero by KnoxBiz 2021. You're a fellow of the American College of Surgeons, a board member of the Knox County Health Department, impactful local involvement with the Lonsdale Health Center and Emerald Youth Foundation. When I went through your CV, I thought, well, if I just read your CV, that'll be the entire session with you today. So that's all the time we have today. So your career has taken on a new complexion, if you will, and that is the chief medical officer,
Sure.
where your responsibilities are as much one-on-one for patients, but now really for the whole enterprise. So tell me about that transition and what led you to that.
Yeah, so I will tell you, I came here 14 years ago with an interest in curing cancer. That was my ambition when I showed up from MD Anderson. And clearly, I had a reality check after practicing surgical oncology 2 or 3 years, but really had no interest in healthcare administration at that time, early on. But what I did have an interest in was just solving problems as it relates to patients, or access for my patients in the community, building service lines, building a physician leadership academy. It was always, problems that I had encountered personally and finding solutions to those problems. And I think that's what led to, me being a candidate for the role of chief medical officer. And in that role, I still get to do, like you said, on a systemic level, but still get to do what made me passionate about medicine in the first place, is advocating for my patients. Now I get to do it instead of one-on-one. I get to do it on a broad, community-wide scale, and also advocate for my medical staff so that they can advocate for their patients.
So let's talk about the community-wide scale for a few minutes. One of the areas of focus of yours has been health disparities, and that conversation is an important one to have.
Yeah.
And increasingly so. I mean, you open up almost any journal today, and there are academic papers about disparities, but also it clearly crosses over in a major way to policy. So can you tell us from 30,000 feet to start with something about health disparities, and really why has it caught the attention of so many people? What has brought it to the forefront? They've been there a long time, and it's been a systematic problem. But now we're paying attention to it. You're one of the leaders in the local community in this area. So tell us something about what do we mean when we say health disparities, and where are we going with this?
Yeah, thanks, Paul. So, as you said, health disparities have always been there. They haven't always been, or the study of the topic hasn't always been top of mind or as popular as it is today. But really, what health disparities means is just a difference in health outcome between groups. Traditionally, when I first became interested in this topic 20, 25 years ago, we always thought that it was related to race and ethnicity. But clearly, disparities transcend that. It can be related to any or difference between any group of people that have experienced social injustices or discrimination, and that clearly goes beyond race and ethnicity. When I first started studying health disparities, it was all about that. And so I was discouraged because I felt that, based on a specific race or ethnicity, your outcomes were destined to be different. There was nothing you could do about it. And then around 2010, we started talking about social determinants of health, and that your health was influenced by where you live, how you live, and the relationships of people in your community. But more importantly, it gave us something to target. We could target people's socioeconomic status. We could target their housing. We could develop green space for them to exercise or build grocery stores in their neighborhood so that they could have access to healthy food. And so it really gave us targets and things that something we could do, change, but also it helped us focus on what our goal was. Heretofore, we had been focusing on just the difference, and everybody described the differences ad nauseum. But now we focus on health equity, which is a target. What are we going to achieve and how we're going to go about achieving that? And to your question about why are we so interested in it now, I think in an era of value-based care, you have to be. You're paid a certain amount of money to manage a population of people, and that population cannot be healthy if you're not addressing the needs of the most disparate demographic of that community.
And it's also the right thing to do.
That's right.
And we're overdue
That's
as a profession to address that. One thing that I want to remark on, you mentioned social determinants of health. I was recently involved in a study critically looking at how it's been measured in the medical literature, and we do a very poor job.
That's
we
right.
do a very poor job of measuring it, partly because we're limited by the electronic medical record to provide us with that information. And so I know there's a movement afoot to become more generous with the fields in EMR systems that will allow us to really understand the patient in totality. In other words, moving away from a pure physiologic assessment of the patient,
Sure.
but taking into account the local environment in which the patient lives. What steps do you think should be taken? You're looking at it both globally, but actually locally as well, and have had a great impact here in the Knoxville community. The outreach in the Lonsdale Health Center and then the free medical clinic. Why don't you talk about those initiatives, because I think it really speaks to the power of your work here.
Yeah, so one of the major barriers that contributes to health disparities is access. And access, people say, wow, how can we have access issues here in Knoxville when we have 3 health systems? But part of access is trust and fear. You can have a hospital or a primary care location right next to your neighborhood, but if you don't trust physicians, or if you fear the outcome of going to a physician, that fatalistic perspective that you're going to discover something bad if I go, those are barriers that need to be addressed. And so in the Lonsdale community, which is one of the most diverse communities in our county, we really partnered with the Emerald Youth Foundation and Cherokee Health to address those issues that we just talked about, fear and trust. So Emerald Youth was already an accepted brand in the community. Cherokee Health was as well. But we were building a sports complex, and we developed a concept called health and community. We hoped that people would access health care if we made it more available to the activities that they enjoyed, i.e. when they were bringing their kids to practice or to worship arts or to after-school tutoring. If we had the access right there in the building, they would be more likely to access it, especially at hours when it was most effective for them. And so that concept has been very successful. We're 2 years into it. They see about 4,000 encounters per year. They address primary care issues and mental health issues, and we hope to add a dental component to that in the future. And then the same thing with the free medical clinic. That disparate group is the working uninsured. We have people that work in service industries every day that make some of our lives very, very comfortable, but yet they don't make enough or have access to benefits. And so we wanted to create that access for them. And so we have had access to that clinic when Dr. Kim, the founder of the clinic, retired. We've continued to develop that clinic. We're seeing probably 4,000 encounters per year there. And we just added a dental clinic to that primary care clinic that's going to open next Tuesday.
I also think that this has awakened a lot of members of our profession to realize that we do have a responsibility beyond the confines of your clinic, beyond the confines of the hospital,
Absolutely,
to address the whys. You know, we used to say, well, the patient's not compliant with their medication and be done with it. But that's not the appropriate response. There are reasons behind that. It's cost, it's access, as you mentioned. Not every neighborhood has a pharmacy, for example.
That's right.
And even then, sometimes those pharmacies charge a lot, depending on their arrangements with their PBMs and so forth. For our trainees today, what do you think are some of the key initiatives or that we should launch? How do we educate our residents and fellows and even some of our colleagues about the influence they can have to improve the lives of patients through initiatives like the ones you're leading?
Sure. So first of all, as the region's academic medical center, I think it's the responsibility of the University of Tennessee Medical Center to address health disparities in our community. I don't know if other health systems will do it. I think they will be obligated to a certain extent, but I don't know that they will have focused initiatives where they can make a difference. It's our responsibility as the academic center. Secondly, we have to do things like what you've done today. We have to talk about it, what it is and what it isn't. We have to get rid of our own biases by having conversations and having educational forums. I know you're putting together a Disparities Month coming up in January. I think that's very important. You've got a lot of different guest speakers coming in. You're going to approach this topic from many different perspectives. I think it's important for them to see all the components of health disparities. Then I think it's important that they engage in some of these initiatives that we have engaged in, i.e. Lonsdale or the Free Medical Clinic. But what we're doing in our emergency department with high utilizer patients and our social worker in the ED, what our urology program is doing with their access programs throughout our 21 county catchment area, just to be involved and see firsthand the barriers that these patients face. And like I always say, there's some things that you can't unsee, and that's where my passion developed when I went into the community and started to understand the barriers that exist. That fueled my passion about the topic.
And it's remarkable because sometimes the smallest actions can make a large difference. I came across a paper recently in which the investigators placed within the EMR system, the electronic medical record system, a templated letter that can be addressed to a utility. For example, if someone is facing the potential loss of heat or electricity because they haven't kept up with their bills, there's a way for the clinician to download this letter, add 1 or 2 lines, send it off. And they followed actually the outcome of those letters, and it turned out that most of the time the patients did not have their power turned off, that the appeal letter worked.
Yeah.
Just making it easy, but also reminding our clinicians to address the issues at hand for our patients. So this has been a really interesting discussion. We are looking forward to January 2022 for Disparities Awareness Month here at the University of Tennessee Medical Center and the Graduate School of Medicine. For those of you listening before that date, please keep an eye on our website at www.gsm.utmck.edu. And if you're listening after January 2022, we do hope to post some of the lectures on our website so that you can download them and listen either directly or by podcast. So Keith, Dr. Gray, many thanks for joining us today in the Faculty Lounge and for this interesting discussion. And we look forward to having you back in the future as we interview other faculty members here at the Graduate School. Until then, thank you for joining us.